Dr. Rao and I have just come to do an overview of gram-negative bacteremia. So looking just really pretty much of a national picture and just to remind ourselves where we are. And then Dr. Rao is going to just present some local data and then just looking at what we can do across primary and secondary care just to try and reduce those bloodstream infections. That's okay. So none of this should be new to you. It's just a bit of a reminder about the government's initiative to reduce gram-negative bloodstream infections, pretty much in line with the antimicrobial resistance report that came out a few years ago, and also the recognition that gram-negative bloodstream infections have got a high mortality rate and certainly high within the NHS, and these figures were from 2015. So just putting it into context of a couple of other healthcare associated infections. So from there you can see the E. coli bloodstream infections in green, really steep curve there. Clostridium difficile, nice downward curve. MRSA bacteremia, a reduction, and then maintaining that reduction. So looking at the gram-negative bacteremias, we can see that we're not really making much headway from that, and it's going in the opposite direction really to what we would want it to be. And this just pretty much reinforces that. So the figures at the bottom are the E. coli bacteremias, and you can see that in comparison to MRSA bacteremias and to Clostridium difficile infection as well. So I think there's a general recognition that we need to be doing something to reduce these infections. So we know from national data that majority of patients have had prior treatments for UTIs, and this has come out as the highest risk factor, particularly in relation to E. coli bloodstream infections. And certainly when there's been national work done looking at those key health events, we know that quite a high percentage of those patients had had antibiotic therapy in the 4 weeks prior to them developing the bacteremia. And again, quite a high percentage of those patients had had a urinary catheter in place as well. So this is where we've done sort of a focus really around the work that we've been doing to try and reduce those bloodstream infections. Again, just to put it into context a little bit more as well, there's not much difference between male and female populations, but we know that the majority of those E. coli bloodstream infections have got a community onset. So I'm just going to hand over to Dr. Rao, so she'll look at sort of more local data and what we can do to reduce those.
Hi, thank you very much. I just thought, Christine has given you the preamble, just thought I will update you on our local data and what we are doing here and what we should be doing in terms of reducing healthcare associated urinary tract infection as well as bacteremia following these UTIs. So 2018-19 we had 192 cases of E. coli bacteremia, and 84% of them were from the community as from the national data. Also it mirrors the national data. Only 31% of these are hospital acquired. Among them, only 16% of them are hospital acquired, and among those, only few were related to some of the interventions done in hospital in terms of either ERC, post-ERCP, post-trust biopsy, but most of them are related to the UTIs. So again, it is most common source is UTI, as I said before also, and as from the national data, even Barnsley mirrors the same. Urosepsis is the most common source, along with the which is only small portion of urosepsis due to catheter also is the source of bacteremia, which is less common than the national database. But other causes are contributing to E. coli bacteremia are biliary and chest infection. But the main focus in terms of reducing bacteremia is focusing on the reducing the UTI, management of UTI, appropriate management of UTI. So that is the most most area we have to concentrate on. So we did root cause analysis for 16 of the cases. We were aiming to do 50, but we couldn't get the data on more than 16. So many of you have been involved, I think, because this is from the community cases, and GPs were asked to give information about these cases. And about from these cases, only 2 of the 16 patients had a urinary catheter, which again goes to show that catheter is not a big problem in terms of having a UTI or having a bacteremia, mainly bacteremia in our patients. 4 patients had repeated treatment for UTI, recurrent UTIs. And very few cases, samples were sent in only 50% of the cases to diagnose. Especially in patients with recurrent UTI, it is very important that you send the sample so that you know what you are treating and what antibiotics need to be used. But most of the cases where we did the RCA, patients repeatedly received trimethoprim nitrofurantoin, trimethoprim nitrofurantoin, occasionally amoxicillin, without having the sensitivity being done, and then they will have a breakthrough bacteremia following that. So again, I will talk to you about the actions we are doing. 9 patients appear to have no any hospital interventions or hospital admissions prior to bacteremia, which is again a common theme coming out of the national database. So this year we did root cause analysis for catheter associated UTI, just to see whether we are following whatever pathways for catheters, and catheters have been inserted for appropriate reasons. So there were 9 RCAs undertaken from the 7 patients, because 2 of them had a relapse of bacteremia, and 6 were male, 1 was a female, age group between 71 to 91 years. It's the same for other UTI related bacteremia also. 5 patients lived in their own home, and only 2 patients lived in care home. Again, we are seeing this pattern. Not many of them are coming from the nursing home, which we thought it could be the reason why they are getting bacteremias, because they are in a long-term care home and they've got catheter in and repeated UTIs and all. But these are mainly coming from their own home. In all cases, catheter insertion was classed as appropriate, and management was also, most of the cases, it was appropriate. So it was not an issue with the Barnsley, and there is a lot of work going on with the continence nurses within the hospital as well as outside the hospital, picking these patients up and monitoring them. So again, this UTI, general UTI, is the main source of bacteremia in our population. So among the catheters, the main contributing factor identified as traumatic removal of the catheter, mainly by the patient pulling the catheter, and that led to bacteremia in 3 of the cases. Other contributing factors related to catheter is blockages, again repeated blockages of these patients leading to sepsis and then coming into the hospital. Among these patients, 3 patients had trial without catheter attempted, which is a good news, and 5 of them was not deemed not appropriate. So everybody was reviewed except for 1 patient, and that is the push we are having in terms of catheters. Keep it only for those days which are necessary for the patient, otherwise take it off. So from this RCA, one thing which came out is catheter pathway is looking better than expected from our previous attempts to look at it. So main aims to reduce, as you know, by 2021, the aim is to, national aim is to reduce 50% of the avoidable bacteremias. Again, until now, there is not much improvement has been seen throughout the national level. We have seen the rate is stagnant from last year's. It is not improved or not deteriorated so far, but we need to do more if we want to reduce gram-negative bacteremias. One is mainly prevention of UTIs and correct diagnosis of UTI, management of this patient, appropriate treatment of UTI, and appropriate management of catheters. So I've divided into 4 categories here. Prevention is key in terms of elderly patients not hydrating themselves properly, so you need to be aware of this, and I know most GPs will advise on prevention. Again, our population is not in nursing homes. Most of these bacteremia cases are coming from the home. So it is for them, educating them and also making sure that they get adequate hydration is important in terms of reducing the UTI. Good. I don't have to teach you this, but I put the points in good personal hygiene, avoiding feminine hygiene products, encouraging bladder emptying, encouraging front to back cleansing and change of incontinence pads frequently, time alerts for reminding the use of toilet for memory impaired patients. So all this needs to go into not only for the patients in nursing homes, but elderly patients carrying themselves in their own home. So diagnostic challenges, it is difficult in elderly patients, the diagnosis of UTI. No one single test will diagnose, and most of these patients will have dysuria, frequency, incontinence without any reason for infection. So it may be that overdiagnosis is a problem with the elderly patients. Comorbid illness may result in symptoms similar to UTI, so that need to be taken care of. And again, cognitive impairment makes it difficult reporting of symptoms. Atypical presentations in older patients, and also asymptomatic bacteria is very, very common in these patients. 18 to 20% of the nursing home patients or patients above 65 will have asymptomatic bacteria. That means you have a positive dipstick in patient, and if you send a urine for a culture, you have a positive urine culture with the organism growing. So that doesn't mean they have got bacteremia. That doesn't mean they have got UTI. So sending samples without any clinical diagnosis of UTI or clinical symptoms of UTI, you will end up treating them unnecessarily. Common reason for treating as in elderly patients, urine smells or it is cloudy. There is no correlation between the smelly or cloudy urine to UTI. So it doesn't automatically trigger antibiotic advice. Dipstick positive, again, we do get a lot of urine samples saying that dipstick positive. They may have symptoms, but it has not been written in the request card. Positive dipstick, because of asymptomatic bacteria, they can be positive. They can be positive for white cell count, they can be positive for leukocytes and bacteria also. But positive RBC, maybe if they are only positive for RBC, maybe look at other reasons for symptoms. Positive MSU is another reason for treating, which is again, as I said, asymptomatic bacteria can give a positive result. So that doesn't automatically require antibiotics. General decline, again, need to review the patient because you may be missing other sources of infection. I do remember a patient who had come in maybe a couple of years back with very general decline and not talking and not feeling well, and UTI was diagnosed and put on trimethoprim, then ended up in ITU, and we had to do an LP because she was not conscious and ended up having a viral infection, viral meningitis. So you may miss if you go down the route of UTI from the first place and not keeping an open eye, open mind in terms of diagnosis of other infections. Urine culture, a culture should always be obtained if you are treating a patient with antibiotics, symptomatic patients, because you don't, resistance rate is increasing year and year. And some of the antibiotics we think may be effective may not be effective for that particular patient, especially if the patients have had a course of antibiotic beforehand. They usually get infection due to resistant organisms. So sending samples is very, very important, and it's one of the criteria for us in hospital now with the new sequin for UTI. They ask for samples to be sent for these patients. Urine culture does not establish the diagnosis, but will assist in selection of antibiotics needed to be used for that particular patient. And negative culture obtained prior to initiation of antibiotics exclude bacterial infection most of the time. So you may look for other sources of infection in that case. First choice here treatment is nitrofurantoin. I'll tell you why. Although it cannot be used in patients with the eGFR less than 45, but in other patients it is nitrofurantoin. And the second choice is trimethoprim 200 milligram BD for 3 days most of the time, but a male or complicated UTI you may have to give 5 to 7 days. We have put in other 2 antibiotics recently in the new guidance. One is pivamycillinam. You may have heard of this, which is again, it is a penicillin drug, so you can't use it for penicillin allergic patients, but it should be in your formulary. 400 milligram initial dose followed by 200 milligram TDS, and also fosfomycin. This is sachet. We can use it as a single dose, not the tablet form or not the liquid form. It's the sachet form, which is cheaper version, and you can be repeated after 48 hours if you are treating a complicated infection. But you can't use fosfomycin or nitrofurantoin for pyelonephritis. Nitrofurantoin resistance is 40% of the nitrofurantoin resistance is up to 2 to 4%, which is again nationally it is 2 to 4%. So that's why we recommend using nitrofurantoin first line, whereas trimethoprim resistance is up to 40% and it's increasing. So trimethoprim may not be the first choice for, especially if you don't know the sensitivities. It should not be used unless the patient has failed on other antibiotics and you are waiting for the culture, the results. And if the culture is available, change the antibiotic depending on the culture sensitivity result. Antibiotic prophylaxis evidence in elderly is limited, so causes much more harm than good in terms of C. diff and candida infections, GI upset and all. So it should be used only when absolutely necessary, when other causes have been ruled out, and that is the only way to prevent the infection. But again, it has to be, we say that maybe you can use it for 3 months and stop and review and see how the patient goes, and if there is no further episodes of UTI, then he or he may not need any more antibiotics. So, and most of breakthrough infections need to be treated independently if they are on prophylaxis, because most of the time they develop infection with an organism resistant to the ones they have been used for prophylaxis. Cranberry product you can use, evidence very small, tend to reduce UTI reduction over 12 months, and it's not available on prescription, so and interaction with the warfarin, so I will leave you to judge that. To reduce the catheter associated infections, first of all, we need to ask whether the catheter is needed for that particular patient, and if it is needed, you can look for other options also. Continence nurse will advise on those things, and ensure that a need for catheter is reviewed frequently, because most of the time once a patient has got catheter, it's easy, and then it gets forgotten, and the number of days, the infection rate goes up with the number of days the catheter is in place. So it is better to take it out when as soon as it becomes the patient it becomes not necessary for that particular patient. Again, non-touch technique while insertion, ongoing care and management. And again, we have seen a couple of patients recently. I had a root cause analysis where a patient had repeated blockages of the catheters, and it was not monitored properly. And again, referring to continence nurse, they will advise on use of different catheters or frequent flushes, and so it may be better to use their service in these cases. And we have seen a couple of patients coming in with repeated bacteraemia because of this blockage. That's about UTI and bacteraemia and reduction plan. I was asked to talk to you about a little bit about the crisis response team. Now they can give first antibiotics also in the community, so that you can refer to them directly for cellulitis, mainly for cellulitis. So for mainly once daily antibiotics, they are using it. So those patients who need IV antibiotics for cellulitis, that's class 1 or class 2, where you think IV antibiotics, they will benefit from IV antibiotics, so you can refer directly to the rapid response or crisis response team. and they can give the antibiotics. You don't have to refer them to the AMAC, which used to be like that before. First dose they used to given in AMAC and then taken over by the crisis team. But now they are confident to give the first dose also, so you can refer them directly. Referral method is by phone, and they've got the phone number there, and also there is a referral form. It should be available, or you can ask from that email address there, which is can be filled in and given it to the patient with the prescription, and they will pick it up from the patients and give the antibiotics. And also there is a consent form on the back side of this referral form, so it can be also, consent can also be taken. In case it's not taken, the rapid crisis response team will take the consent. They will visit them every day to administer treatment and monitor the patient. So if there is anything, if they're not happy with the patient or the cellulitis is not improving, they will inform you so that you can review, and you can, or IV access is problematic, they will contact you. So that's a good service running for nearly many years now in Barnsley, but mainly through the Barnsley Hospital. But now they're taking the referral from the community also, which is, I think, for cellulitis is a good way of avoiding hospital transfers. So that's it from me. Thank you very much. Any questions?
Sorry, Dr. Who is prescribing IV antibiotics? GPs or?
Yeah, GP has to prescribe now that it is taken by the rapid response from, they can give the first antibiotics, so it has to be prescribed by the GP.
Don't we do any blood cultures?
Those need admission. If you think if blood cultures are needed, mainly.
Cellulitis.
Yeah. It's mainly the wound swabs, I think. Bacteremia is unlikely in class 1 and class 2. But if you think the patient is unwell enough to have a blood culture, then he needs hospital admission, or at least AMAC, and then.
It's often the urology colleagues that recommend prophylactic antibiotics
Yeah.
in letters, and often we can get into a bit of a difficult situation when we're getting different advice. Is that something that you're working with them?
Yeah. They assure me they use it only when that is necessary. But I think putting a stop date 3 months, which I think they're not very good at, we need to follow that up. But I think you are right. You are within your limits to stop that after a certain time and review the patient.
And if a patient don't respond to the IV antibiotics,
For cellulitis, you are talking about?
they bring the GP back, isn't the key?
Yeah.
Why can't they admit the patients? Because we wouldn't do anything different, and they already don't respond like that. It's going to take it to the GP.
No, maybe if the patient is unwell, they may refer to the patient. They usually talk to us also before talking to you if there is a change of antibiotics. So it may be that we just need a change of antibiotics, which they can be given by the GP. But if the GP can't maintain that, or if there is no antibiotics which can be given once daily, or if they need hospital admission for any other reason, they need to be referring to hospital. I don't know whether they can directly refer or not. I think it needs to come from the GP.
They can do through the right care process.
Okay. It's only for those who are septic and cannot, It may be that sometimes it just need a change of antibiotics.